Good evening. Welcome to this edition of the Evening Review. My name is Jemima Bierkes, your host this evening. Now, Namibia has made history last week when we had a team of Namibian cardiac specialists under the leadership of Dr. Fenny Shidhika performing a number of cardiac operations for the first of its kind in Namibia. And we have in studio Dr. Fenny to talk to us about what took place in Windhoek last week. Thank you for joining us, Doctor.
It's my pleasure and privilege to be here tonight.
Doctor, can you tell us about the operations that took place last week?
Yeah, so just for insight, we started this program. I'm a pediatric cardiologist, that's a children's heart specialist. That generally deal with patients that are born with congenital heart disease or structural heart disease, which is way distinct from adult heart disease, which people commonly know. So I trained in South Africa, the University of Cape Town affiliated hospital, Red Cross Children War Memorial Hospital. So I came back to Namibia in 2018, July, and that is when we effectively started doing congenital heart surgery for the country, because the patients usually, in general, in the past went to South Africa for surgery. Mm-hmm. So we started in September 2018. So we've been doing routine surgery, but because of lack of critical, highly specialized, trained capital, we had to start off with low-risk procedures and moving on exponentially with high-risk procedures. And we have been doing surgery throughout, actually since then, for the 6th year now. But we were cautious, particularly about doing complex neonatal surgery, that's in the newborn, as well as very complex structural lesions, like the ones that we did in the past week. So for the first time, I was sort of happy with my team, because we had a visiting team from England, from Newcastle upon Tyne Hospital, mm-hmm. Led by Dr. Mohammed Nassar, and another intensivist from Bristol in the United Kingdom. So they came to support our team to be able to conduct this critical and complex operations safely. So what we they needed, importantly, was the critical care team, the nursing team, because generally we work in a multidisciplinary fashion, so I cannot work alone as a cardiologist. So I work with cardiac surgeons, I work with cardiac anesthetists, I work with nurses that are trained ideally, particularly in congenital heart disease. I work with intensive care specialists that are trained ideally in congenital heart disease. And I work with perfusionists that run the heart-lung pump machine, and the sleep doctors, so we call them cardiac anesthetists, that are particularly trained in congenital heart disease. So our current team currently is constituted of myself, serving the whole public service of Namibia. We have one trained congenital heart surgeon, Dr. Alfred Mureko, who has trained initially as an adult cardiac surgeon, and he had to specialize further into congenital heart disease. And he's assisted by Dr. Awala Ismail, who is an adult cardiac surgeon. Then we have a cardiac anesthetist who was probably the first Namibian heart specialist in the country in 2013, that trained specially for heart anesthesia, and so far he's the only certified cardiac anesthetist in the country. All of us, basically, we are on our own. And we have a perfusionist. He came from South Africa, because Namibia, again, doesn't have that critical capacity. So he is trained, again, to perfuse both mm-hmm. adults and children, and he's been here now for 10 years. And now we have intensive care specialists who are mostly general ICU specialists. And this team that came last week was complete, mm-hmm. because they do cardiac operations every single day, and complex ones. And importantly, they are trained specifically for congenital heart disease, especially the nursing team. And the ICU specialists also, they were specifically trained for congenital heart disease. And that is important, because congenital heart disease is complex and it's got a lot of nuance. And you have to be trained in it to actually understand the physiology and how you actually tailor your management. We should be individually tailored as per lesions. And I think what makes it complex is that there are too many lesions. And while there is that heterogeneity, there is also an individual pattern. Just because you've got the same lesion, it doesn't mean that you will behave the same way, because everybody has their own physiology and genetic code. And that is sort of what determines the behavior going forward in their postoperative care, for instance. So because I had a good team, I thought we were ready to engage complex stuff. We generally sensitize our teams way beforehand, so I share a list of the patients that we intend to operate on. Under normal circumstances, these operations would be going to South Africa, because my team we only are doing a certain level of thing. We have risk stratification scores from 1 to 6, and we have started doing 1, 2, 3 comfortably, but the high 3, 4 to 6, those ones I still send them to South Africa while we are developing local capacity, full local capacity with trained cardiac nurses, with everybody. But I'm pleased and very privileged to say that our nursing team probably has done the most pediatric and congenital heart disease care in the country. So I'm more comfortable to work with them than any other hospital in the country. So
you mean the state nursing?
Absolutely, absolutely. And equally the doctor's team, I have a full set that is not found anywhere else in the country. So I'm more comfortable to operate besides the fact that we're dealing with 90% of the population, and the variation then means that you've got enough volume to keep you relevant as a cardiologist or as a surgeon. And that's the reason why we do that. So we did, all of them were complex.
Can you just give us in layman's term what you did last week? So
we did about 9 operations. So 3 of them, they were getting done in the country for the very first time. The first one we did on Tuesday starting was, so Monday we did tetralogy of Fallot's. That we have done before, and we've got a very good survival rate in general in Namibia since we started our congenital heart surgery program. On Tuesday, we then started off with a newborn who was 3 weeks old with transposition of great arteries, and that's when the pipes that supply the body and the lungs respectively are bone switched around. And now the duty of the surgeon is to try and switch them back in such a manner what God would have created the heart to be. But this one had a little bit of nuance around it. So the hole that is cardiology is like physics, but a physics of blood flow. So transposition of great arteries, we call it parallel circulation. And to be able to be alive, you need to break that parallelness, because the circuit of blood flow is supposed to be in series. And you need a communication usually between the two top chambers of the heart to mix blood and make sure that there is enough mixing in that parallel circulation. So this one was born with that small communication, and I had to break it to open it before we prepare the patient for surgery, because he was on a ventilator and was critical, and we could not have kept him like that until the operation. So I had to break and create a new hole, a bigger hole in the interhydral septum between the two top chambers of the heart before the definitive procedure. And while we were waiting for that, we had to keep a certain pipe open called a patent access arteriosus. But those are abstract things, and I don't want to get too much into the detail of them. So the surgeon successfully switched the pipes around. Of course, it was a complex operation because it's a newborn, 3 weeks. The organs are immature, and you have to connect them to a lung pump machine. In the baseline of the patient, there was infection in the background. There was a lot of things in the background. So we started off with what we would call a moderate substrate. And that usually means that then the bypass might get complicated, and the technical implications are also quite serious because it's a very complex operation, and a lot of surgeons are still finding their feet doing it properly. So she done perfectly as it should be. The postoperative care was a little bit hard, but we had a very trained team, and the patient now is de-escalating nicely, is recovering nicely. So that was Tuesday, and then we did another operation, but it wasn't so complex because we don't like mixing complex with complex. We like mixing them up so that you can tailor and make sure that you have nice acuity over the patients in the cardiac ICU. Then on Wednesday, we did even more complex. It was a patient with quite a history, 12 months, 13 months old. He was born and we diagnosed him at 2 months old. And what had happened to him is that he had gone to Cape Town. I had referred him there, knowing that those kind of cases, as I said earlier, they were going to South Africa, to Cape Town, where we trained to handle them and operate them there. But then he went he was having an infection at the time, and he was cancelled on those merits, which was appropriate, because the infection was so bad, and it was a bad bacteria that causes infection in the heart even, and it was causing multi-organ dysfunction. So they cancelled him, and they said, we cannot engage on a big procedure under these conditions, which was acceptable. So the patient came back. He had been airlifted there because he was oxygen dependent, and we looked after him, and then he recovered. And then we sent him home on oxygen. And I told the mother that I will get you a team that can fix this ideally locally, but my Cape Town colleagues, or my senior colleagues that trained me, were prepared to take the patient back in the future. So I decided to include him in the list, so he was done last Wednesday. That was the biggest operation that even in South Africa, not a lot of centers can perform it. It's called a Tausig Bing malformation. So it's a different type of great artery switched around with a big hole in the heart. But there's a lot of technical work that needs to be done there and needs a lot of technical expertise to perform it safely. Now, the surgeon who came was helping our surgeons. There were 3 trained surgeons, one more experienced than our surgeon, and then another surgeon, the 3rd adult surgeon. So they did it perfectly. It was too perfect that when I went to check it in theater, because they would call us to check when they are done operating, to check whether the repair is fine, is there anything that needs to be modified. I almost cried because I never thought it could happen, firstly, and the patient would be alive. I thought, because there's always risk, and this kind of patients can actually die on the table because they've got high blood pressure because we were flooding their lungs all the time. And secondly, it was too perfect. I could not believe that it's actually done the way it was done. So I of course, I'm human.
Yes, of course.
So I got a bit emotional, and So it was done. The patient is doing great. He was taken off support the following morning and is doing fine now, and is probably going to be discharged soon. The other one that we did was, again, a very rare variant of a vascular ring, we call it in medical terms, where the arch doesn't, the pipe that takes blood to the body doesn't take the normal course. So it came off the right side as opposed to the left side, the way it should. And then it came, and then it crossed behind the food pipe and the trachea, that's the airway, and caused obstruction of the trachea to travel around the left side of the heart. So it did a crossover. We call it we call it a right arch with a circumflex aorta. Very rare lesion globally. Personally, I had never seen it before. But luckily our surgeon who came had seen it and operated on one before, but it's very rare. It's like one maybe in 20 or 30 million. And a lot of people have not seen it at all. So, and that is the kind of heart disease we have in Namibia. We have classics that are not even in the textbook. Like this very one, I've never read it in the textbook. So I had to share with my colleagues from outside the country the CT images that were done by a cardiac radiologist who, again, was in the state. He's a radiologist that trained at the University of Cape Town like ourselves. So we did a CT scan, and then we looked at it, and it was atypical. It wasn't your usual variant of a vascular ring. So it was operated successfully again. So they had to move the aorta from the back, or that pipe that supplies blood to the body, from the back, and uncross it, put it to the front so that it does not compress the trachea and the esophagus, which is the food pipe, because they were causing problems. She couldn't breathe nicely, and she couldn't eat nicely without throwing up and all that kind of stuff.
So, doctor, when you say we have classics, can you please share a little on these strange cases?
So those are like, as I said, is lesions, because cardiology is a new field. Heart disease, congenital heart disease is a new field from the 1940s, 50s there. So, and you have textbooks and written papers and publications from the past. By classics, I mean that the kind of variation in anatomical substrates you have in Namibia are just too rare that you don't even find them in your textbook of pediatric cardiology. That's how, and it fascinates me as a cardiologist because, as I said, I trained in South Africa and I've been to Europe, in France and Britain. And I read all the time other opinions from all over the world, but the kind of lesions we get in Namibia, the combinations sometimes are too atypical, and the textbook had said that it's not possible, but that's the kind of stuff that we have in Namibia. Now, interestingly, because we know that there's a genetic etiology in general, congenital heart disease, that is, we are doing genes supported by the University of Cape Town, where we are trying to collect the genetic profile of congenital heart disease in Africa and create this genomic bank for Africa to study exactly the genetic etiologies and novel genes or new genes responsible for congenital heart disease. And our first analysis of the first samples, we've capacitated NIP, that's Namibia Institute of Pathology, to isolate the DNA. We store it locally and in a special fridge after isolation at minus 80 degrees. And then those samples are then sent to Cape Town for analysis. They've got a huge genetic lab there at the University of Cape Town, and they informed us the provisional first results. They said they've never seen something like that before. And we are still collecting. We're currently busy with a new cohort, collecting mostly for the patients with special lesions that don't have classic syndromes or associations, genetic associations. And they said our cohort was different, completely different than compared to the South African cohort, and importantly to the global cohort, because the genes that are in the textbooks describing congenital heart disease are mostly from Western countries. They don't have an African profile. And the point of this study is to describe the African profile and add to literature and to the textbook the genes that were not known before to be responsible for congenital heart disease, and particularly in the African population. So it's a very interesting thing, and the numbers themselves also shock me as a cardiologist, having been around other places in the world, because the numbers are too high for a population of 3 million people. It's too much. It's strange. So I think...
Why do you think that is?
Because when I was training in Cape Town, it was about 4 million people. Then they were also servicing outside areas of Cape Town, the West Coast and Eastern Cape, and some complex lesions from all over South Africa came to Cape Town. And if I compare Namibian numbers that we see, they're almost the same. But South Africa is a bigger population. So in Namibia, I think there's an element called epigenetics, where, for instance, the environmental factors come and change your genes to behave and act in a different manner that is conveying wrong messages while the heart is developing. And the heart development is very complex genetic-wise. There's so many genes talking to each other, and some are switching on, some are switching off. It's a very complex interaction. So you're fortunate to have a normal heart, in other words. And I think there are environmental factors, but we know certain things that have been described, like heat, climate change. The incidence of congenital heart disease seems to be increasing with climate change, so it's a hot topic of discussion.
Pun intended.
Yeah. Unintended consequences of climate change. Dust, once it exceeds a certain size, and we know our weather and our climate is different. So I think there is also that element. That study was done in China, and I think in India also, studied dusty places, and they found that the areas that were having dust with certain particles of a certain size were more predisposed to congenital heart disease than others. And then issues like socioeconomic factors, obviously stress, nutrition, all those things are associated with congenital heart disease, but also the teratogenic factors. And we know that in Namibia we have a high incidence now of diabetes in pregnancy. That is also causing congenital heart disease. rare cases of fetal alcohol syndrome as well for the mothers that were drinking during pregnancy, and certain medications. We call them teratogens, or medications that cause embryopathy as the heart develops. But those cases are fewer compared to cases that we cannot subscribe to anything.
Yeah.
But then also there are certain lesions that have got family patterns. Meaning that once you have it, you have to check the whole family because there is a known familial pattern. So it's a very complex field, cardiology that is, and you have to consider the genetics, the way the heart forms, the factors that affect the heart as it forms, and their associations, and you look at the whole body as well, because you might have neurodevelopmental problems, you might have kidney problems, you might have gut problems, because the heart as it develops, it is encased by these layers that where the heart develops from in the skeleton, but also where the gut develops from. So there is that complex interaction, and it's not unusual that we find heart disease associated with brain abnormalities or kidney abnormalities or gut abnormalities. So when we look at them, especially before the operation, we have to do a comprehensive appraisal, considering all these factors, and that is why it's a highly specialized field. Because if you don't consider the syndromes and the associations, you take a patient to surgery, and then you have a poor prognosis and a poor outcome because the appraisal was not complete, and that's the implication. And I know people didn't know about this congenital heart disease, but it's serious. And almost every person in Namibia has got either a family member or a community member or a neighbor with congenital heart disease. And I think it's time we actually make it as a priority and part of policy or national health policy in general.
Speaking about policy, do you think government is putting enough money into addressing this issue?
Not at all, not at all. But I must say before I go ahead that the government of Namibia is unique, especially when it stands against other African countries and other emerging economies, except South Africa, because the government invests in healthcare for its people. Some people are paying out of the pocket. Some people, there's no health insurance, national health insurance for the people at all. So government should be applauded for that. But of course, it's teething issues. This country is developmental. It got independent yesterday. And the implications of it being a new state of sovereignty are there. And that's what we are dealing with now. So we're teething, but we believe that if we modify things a little bit, things will get better. Because, for instance, the budget for cardiac services, I must say that the cardiac service for the Ministry of Health was its pride project. So they invested a lot in there. Machinery, the infrastructure is absolutely proper. But maintenance going forward then had gaps. And the budget, of course, is dictated by the economic climate of the day. So if you got a recession, then you suffer. If you get a pandemic, then obviously you have to repurpose the funds to that current emergency. And then obviously you compromise, but there's always opportunity cost that comes with this. And sometimes it's hard to make decisions around what you sacrifice and what you trade off. Yes. And sometimes these trade-offs have got negative impacts on critical areas like healthcare. And that's what happened for the pandemic. During the pandemic, for instance, the budget was decremental. It has been getting lesser and lesser. But we know that the budget, that healthcare budget that the Namibia government gives to healthcare is enough. I think it's the way it's handled. There are no calculations. Our budget for cardiac service is ring-fenced, but it's only 7 to 8 million per annum currently. It used to be much more, and that is for all the services that are affiliated with cardiac care. Adult cardiology, adult cardiac surgery, pediatric cardiology, pediatric cardiac surgery, anesthesia, perfusion, ICU, and all those things. It's not enough. Now, there are solutions. The solutions, as I said earlier, I mentioned that I did health economics as well in cardiovascular sciences, which gave me insights about administration as well as how to calculate budgets, let's say, for cardiac services. You must have a prospective budget dictated mainly by the number of patients you are planning to save per given year. And you make those calculations, they are tested calculations, and they are called diagnosis-related groups or case mix calculations. And that informs the Ministry of Finance then to allocate an appropriate budget exactly for the number of patients that you would like to address for that given year. In that presentation, I'm still due to give it to the Ministry of Finance together with the Ministry of Health. But I think to retaliate again, it's important to applaud government that it supports the 90% and more of the Namibian population with heart services, with the little they give. But we also know very well that government alone cannot afford cardiac services without corporate support and all the other goodwill offerings from other places. And that is why I developed a Namibia National Children Heart Trust. And the point of all that is Section 21, registered with the High Court, it's got its own tax rights, and it's audited formally. And the point was to try and assist government in collecting more resources to allow more access, which is not geographic access per se, but financial access, so that we can save more patients, knowing our burden is huge, and to make sure that we've got quality and safe, and importantly, sustainable care, because we cannot afford not to have this service. If you count the cost effectiveness of these things, for instance, talking as a health economist now, it's relevant. But we have to ration certain things, like for instance, centralization, where we say you only need one heart service for a population of 3 million people. So we need one service, and then we invest everything there, we develop critical capacity right there, and then we service the whole country. But important is to say, because Namibia is a large area geographically, you need effective transport systems to get people to the right place, to get the right care at the right time from all over the country. Right now, that transport system is defective. We don't have the state doesn't have air ambulance, which is deeply unfortunate. But there are solutions again. It depends on how you want to think about it. So the defense, for instance, the government can use the defense helicopter to transport patients from wherever, and that would be at a less cost than outsourcing it to the private sector, for instance, which is a lot of money to just airlift a patient from the north. But we've had to use that service for patients that need support and they cannot travel safely without support. So there's a lot to be done. But I see a solution, and I think that I don't look at these challenges anymore as challenges. I look at them as opportunities. And I believe that this country, with this huge resource capacity, we can get these things done. But we need to decide that we want to have them done and how we want to have them done. And they will be done. And I think we have the capacity, absolutely, with our natural resources, to be like Great Britain. Absolutely. It's all man-made. We have to decide on that culture in order to achieve all these things. But I believe it's possible, and the potential was always there. It's a point of trying to exercise it and going for it and making things happen. Yeah.
Thank you very much for joining us and sharing all this important information with us, Doctor.
It's my pleasure and privilege always. Yeah.
Thank you.
Thank you.
Thank you for tuning in. Until next time.